So, Chapter 7 in Burnell is titled Physician Behavior, but many of the economic perspectives on physician behavior considered in this chapter also apply to other providers. After reading Chapter 7 in the text, you should be able to explain the benefits of physician group practices for consumers and providers, describe the various ways market power manifested in healthcare markets, discuss monopolistic competition in the context of physician markets, summarize the various physician payment mechanisms and the incentives they create, describe the factors that influence small area variation, explain the theory of supplier-induced demand and how the target income hypothesis is related to the demand for physician services. And lastly, explain how price sensitivity is related to price discrimination. Burnell notes that in 2008, 24% of physicians were in a solo practice, and by 2012, only 18% of physicians were in solo practices. The figures in this chart are the most recent figures I could find on the percentage of U.S. physicians in different practice groups. You can see that between June 2013 and December 2015, the number of physicians in small practices was declining, and the number of physicians in large practices, including practices of 500 or more physician providers, has increased considerably. In recent years, we've also had major growth in hospital employment of physician and hospital ownership of physician practices. In January of 2013, you had about 15% of physician practices owned by hospitals, and by January of 2018, it was more than 30%. Also, in January of 2013, you had slightly more than 25% of physicians employed by hospitals. That figure rose to more than 40% by January of 2018. So you can see this constitutes a large consolidation in the healthcare sector when we have these large hospital systems acquiring physician practices. So this raises the question of why physicians are willing to work in group practices in the very beginning. And Burnell notes that physicians in their group shared the responsibility of running the business. And in some sense, they can specialize more on their own specialty and outsource the management of that practice to others. They can gain a greater knowledge base by sharing information and knowledge about best practices with other specialists and providers. Also, they can increase their market power, and we'll talk a little bit more about that in just a moment. Lastly, they experience easier patient referrals within the practice. So with regard to the economics of a multi-specialty group or group practice, it is more feasible to be in a group setting. The text also notes that these practices achieve both the economies of scope and the economies of scale in service provision. So economies of scope here is thinking about how using the services of different specialists in the same practice that might be more practical and convenient for patients than having to shop around for specialists in different practices. Providers also benefit financially by referring their patients to providers in their own practice rather than to providers in another practice. Economies of scale here refers to the idea that you're dividing out those upfront fixed costs across all of the providers and all patients for that practice. So costs such as the building lease and the salaries of front-end staff are spread among the providers. This also leads to significant market power for the physician group or multi-specialty practice, and this allows them to essentially influence the terms of the exchange regarding the price that is charged to patients or insurers regarding the prices that are paid for supplies and other inputs regarding the quantity of services provided and the quality of those services. In practice, most healthcare prices are negotiated between different entities in the healthcare system, and the resulting prices look like differences in the market power of those entities between insurers' buying power and providers' selling power, for example. So that's why group practices might have greater bargaining power and leverage over those physicians who are in solo practice. In essence, to combat rising consolidation and market power of insurers, you might have an incentive for primary care physicians to join group practices, and especially to join large hospital systems, because those systems might have considerably more bargaining power with regard to the reimbursement rates they've received from insurers and even from public payers. We're talking about market power in healthcare. We're talking about the ability to negotiate higher reimbursement rates for services rendered, the ability to set a price that's lower than the competitor's price because there's some cost savings due to economies of scope and scale, for example, the ability to benefit from federal, state, or association regulations. For instance, scope of practice regulations or certificate of need regulations, which both essentially limit supply and competition in healthcare markets. They might also be able to obtain an economic advantage through tax exemptions for nonprofit firms. And this, in essence, leads to more after-tax resources for those organizations, which then allows for greater investments in quality improvement, patient-centered initiatives, the ability to charge lower prices, etc. And so on the other hand, they might also be able to set higher prices than would be set in a competitive market because of the limited competition and high market concentration. In essence, this shifts the ability to set prices and quality and the quantity of services in the hands of those entities with that market power. If you think about the overall labor market effects of barriers to entry, including certificate of need regulations or scope of practice regulations, in essence, this is restricting entry into those markets, leading to a relatively low supply. This in turn leads to a higher level of earnings and in equilibrium and a lower level of employment in those labor markets that have significant barriers to entry. So to summarize, if occupational regulations restrict entry, this will lead to a higher level of earnings and a lower level of employment for the healthcare professionals in this labor market. And that, of course, leads to an incentive to lobby for those types of regulations. However, from a patient's perspective, these types of occupational regulations restricting supply ultimately lead to higher health care prices and lower service provision relative to what would be the case under free entry. And this is just one example from a recent paper on the effects of occupational regulations on the costs of dental services, which found empirical support for the idea that when you have occupational regulations in place, this essentially leads to higher costs for patients and a lower quantity of service provision. As we noted in the last module, healthcare goods and services are often highly differentiated, and given product differentiation, each provider will have its own individual market, and this implies that each provider faces its own demand curve for the services that are being provided, and each provider or firm, and therefore set its own price higher than it could in a competitive market. And so, as we saw in the last module, Under perfect competition, the price that's charged is essentially driven down to the minimum average cost, and it's also driven down to the marginal cost of service provision. However, under monopolistic competition, providers have some pricing power, that is, some ability to raise prices above marginal cost, even though in the long run, because there's still competition, those prices might reflect the average cost of service provision. At the same time, there are instances in which profits for providers can be quite high. For instance, if demand for a given provider service has increased, perhaps because the quality of the services that are being provided is quite high, or as discussed in Chapter 7, because the supplier is essentially inducing increased demand for the services that they are being provided. This could lead to a situation where they are experiencing positive economic profits. So each provider will provide that quality of service which is given by where marginal revenue is just equal to marginal cost. They would then go down to the quantity axis, provide that quantity of service, or see that number of patients, and then go up to this new demand curve after we've had this increase in demand, and charge that price that patients or their insurers are willing to pay, and then they would incur the average cost of AC. For that quality of output, and the difference between price and average cost for the quality of services provided is that essentially that provider's profit. So this would be the case when demand for a given provider service is quite high. That would also lead to higher profits and higher incomes for that provider. On the other hand, if patients or their insurers are not very price sensitive, and you have a low price elasticity of demand, this could also lead to a situation where the provider is able to charge a price that is much greater than the marginal cost of service provision and greater than their average cost of service provision, which leads to higher income for those providers. And of course, the price elasticity of demand for a given provider service that will be influenced by the patient's income and ability to pay their insurance coverage, and the generosity of that insurance coverage, the availability of other providers or substitutes on the market, among other factors. Now, to summarize this rather lengthy paragraph, with a higher demand as shown to the left, or less price sensitivity or less price elasticity demand as shown on the right, the provider's pricing and profits may be higher than what is presented in Chapter 6. Regarding that price P that's paid to a provider by their patients or insurers, let's now consider the physician payment methods that we see in practice. Under a fee-for-service payment method, we have reimbursement rates set for negotiated on an annual basis, and under fee-for-service arrangements, the provider has the financial incentive to provide more services, perhaps to induce a higher demand for the services that are being provided, and to provide more intense services given the potentially higher reimbursement rates for those individual services. In contrast, under capitation, where you have a per capita or per patient payment being paid to the provider has an incentive to keep patients healthy and use fewer services or use less expensive services, because they're being paid for each patient that they're seeing and not for the level of service utilization. And under capitation, less utilization leads to a higher profit level for the provider, simply because you have fewer variable costs being incurred by the provider for visits or diagnostic testing, for instance. So under fee-for-service, the provider has a strong incentive to increase utilization, but under capitation, there might be a weakened incentive to increase utilization and perhaps the incentive to reduce utilization of services. Under a salary payment method, perhaps combined with a year-end bonus, you might have a situation where the provider is incentivized to perform at the highest level. Maybe something in between the fee-for-service incentive and the capitation incentive, and to be aligned with the organization's economic strategy. In practice, we might also observe payment across subsidization, and in which insurance carriers or patients who were paying the greatest amount for service effectively subsidized the care of those patients who paid the least. So if private insurers are reimbursing providers at much higher rates than, say, state Medicaid programs, the provider might be able to use the resources provided by private insurers or a high ability to pay patients to provide services at lower prices for those who have limited ability or willingness to pay, or where you have public insurers such as Medicaid paying relatively less. Empirically, the differences in reimbursement rates do influence provider behavior, and a recent study found a positive relationship between Medicaid reimbursement rates and access to doctors. This study in particular found that due to an improvement in access to doctors led to a rise in healthcare utilization and improved health outcomes. So this was suggesting that if you're providing greater reimbursement rates, it will lead to improved access to healthcare, and we'll take a look at that in greater depth later in this module. As many of you know, across the country, we have a lot of variation in the healthcare prices and reimbursement rates that are paid for similar services. We also have a lot of variation in the diagnostic tests and treatments that are prescribed, overall service utilization and healthcare expenditures. In Brunel, it's noted that every community, region, or state has unique cultural norms surrounding physician payment, medical recommendation, and intervention, and also treatment preferences and service usage. So this refers to a small area of variation in treatments, prices, and utilization across the country. Recent studies have explored variation in inpatient hospital prices. For instance, this study titled "The Price Ain't Right: Hospital Prices and Health Spending on the Privately Insured" documented this market variation in the average inpatient prices for hospital care across the country. Other studies have explored cost variation for things like knee replacement procedures, where in Philadelphia, for instance, the minimum cost was a bit more than $17,000, while the maximum cost is more than $46,000, a 163% price differential. And we also have other cost variations like this across the country. The previous chart was regards to knee replacements. Here you can see this is for hip surgeries, and you can see the variations. Lab studies can also create great variation. Here you see the variation for office-based lower back MRIs. There's a tremendous price fluctuation, not only for these kind of tests, but also other diagnostic tests and other surgeries and other types of imaging. Another idea explored in the text is that of supplier-induced demand. This refers to the idea that sellers, in this case we're talking physicians, may be motivated to offer buyers, or in this case we're talking patients and other consumers, potentially unnecessary goods and service to increase their income. in healthcare settings refers to frequent follow-up visits, potentially redundant tests, and expensive surgical procedures instead of less expensive therapies and non-invasive alternatives. If there's evidence for supplier-induced demand, that would constitute exploitation of the principal-agent relationship between the patient, who is the principal, and the physician, who is the agent, and who's supposed to represent or act in the best interests of the principal, given their superior knowledge and expertise. And this would also constitute a breach of ethics. Another idea that's related to supplier-induced demand is the target income hypothesis. And this is the hypothesis that suppliers might alter their work to maintain a specific income level. When physicians see their income dropping, they may order unnecessary tests, follow-up visits, or recommend unnecessary services just so they can reach their target income level. I know from personal experience as a patient, I found very little evidence of supplier-induced demand for tests or follow-up visits or services being offered that were not directly related to my health needs. And for that reason, one could view these studies with a bit of skepticism. But empirically, that doesn't mean that they don't exist. It's just something that we should keep an eye out for these types of tests and look at the data as we collect it. Here ends the presentation for Chapter 7, Part 1.